Hello and welcome to M.D.Zafar lectures. Today I'm going to continue our talk of the upper limb anatomy quick guide for MRCS Part A. The question is that from which structure does the long head of the tricep muscle arises? So it arises from the infraglenoid tubercle which is present over here. Now important thing is that the tricep has three heads. So this is for the long head. Now it has another head. Now this head is the lateral head. Now this arises from the posterior aspect of the shaft above the radial groove. Now behind these two there will be a medial head as well. Now medial head arises inferior to the radial groove. So radial groove is, for example, present over here, and so the lateral head will arise from above this and the medial head will arise below this level on the posterior aspect of the shaft of the humerus. And the tricep is supplied by the radial nerve. Now there is an important point that as this is the infraglenoid tubercle, so on this point there will be the supraglenoid tubercle, and from that there will be origin of the long head of the bicep. So these two are very confusing points. From the infraglenoid we have the long head of tricep. From the supraglenoid we have the long head of the bicep muscle. So next up we have a 43-year-old typist who presents with pain in the dorsal aspect of the upper part of forearm and weakness when extending the fingers. Triceps and supinator are both functioning normally. However, there is weakness of most of the extensor muscles and there is no sensory deficit. So which nerve has been affected? So when we talk about the extensor compartment, we have only one nerve, that is the radial nerve. But if with the description of radial nerve there is no sensory deficit, then the answer will be posterior atrocious nerve, which is one of the motor branch of the radial nerve. So radial nerve become entrapped in the superficial part of supinator muscle. As you could see that this is the supinator muscle and the radial nerve is going to divide into superficial sensory branch and the deep branch. Now this deep branch is known as the pin and it passes between the two heads of the supinator muscle. So this is a separate MCQ in itself as well. So between the passage of these two heads, the radial nerve can either get compressed or it can get damaged. So if there is a firearm injury or any fracture of this area which involves radius specifically, it can cause damage to the pin. So in that case, there will be only loss of the extension of the fingers and wrist because the radial nerve has already supplied tricep above the elbow. So the function of tricep will remain normal and there will be no sensory deficit in case of pin. So next up we have that which muscle is supplied by the musculocutaneous nerve. There will be different options, so you will be choosing brachialis. So the mnemonic for the musculocutaneous nerve is the BBC. We have the biceps, which is over here. Then we have the brachialis and then we have the thoracobrachialis. So BBC is the mnemonic. Now this is the motor innervation of the musculocutaneous nerve. After passing the elbow joint, it becomes the lateral cutaneous nerve of the forearm. So it supplies this area of the forearm. So musculocutaneous is a mixed blood. It has the motor supply as well as the sensory supply. So do let me know in the comments that from which area of the brachial plexus is the musculocutaneous nerve taking origin. So we have a 72-year-old man who has an end-stage vertical ischemia and axillofemoral bypass has been performed. Which structure is not closely related to the axillary artery? So that is the scalenus anterior muscle. So as we know that this area is of the axillary artery, so it arises from the lateral border of the first rib and then it goes till the lower border of teres major muscle. Now in this area there is a relationship of pectoralis minor and there are relationship of the cords of the brachial plexus. However, scalene anterior is related to the subclavian artery, so it is present at a very far distance. So these are the structures which are related. However, anterior scalene is quite distant. So axillary artery is continuation of subclavian. This is surrounded by the cords of the brachial plexus, and so does the axillary vein. It lies along the paths of the axillary artery. So if you want a better understanding about the axillary artery as well as the vein and the brachial plexus, kindly check my video on the anatomy of the upper limb, where I have explained all these structures in complete detail. So a man had an incision sited that runs 8 cm from the deltopectoral groove in the midline of the chest. Again, the question is which is not at risk of injury. So the answer would be shoulder joint capsule. So as we know that the deltopectoral groove is between the deltoid and pec major. So cephalic vein runs through this deltopectoral groove. As you could see that if there is an incision which is sited 8 cm from the deltopectoral groove, then shoulder joint will be in complete opposite direction of the deltopectoral groove. So it will not be at risk. So the structure pierced by the clavipectoral fascia, this is very important, so I have added this over here, is the cephalic vein, thoracoacromial artery, and the lateral pectoral nerve. So this is highly tested in the form of MCQs, that which structures are pierced by the clavipectoral fascia. So the next question states that which is not an intrinsic muscle of the hand. So as we know that palmaris longus is the muscle which takes its origin in the forearm, so it is not an intrinsic muscle. So what is an intrinsic muscle of the hand? Intrinsic muscles of the hand are those muscles which take their origin as well as insertion inside the territory of the hand. So this includes 4 categories: the thenar eminence muscles, the hypothenar eminence muscles, the androchiae, and the lumbricals. So rest of the muscles enter the hand through wrist joint and they take their origin either at the elbow or in the forearm. So what are these muscles? We have the abductor pollicis brevis, operans pollicis, flexor pollicis brevis, and adductor pollicis. These are the thenar eminence muscle. And then we have the operans digiti minimi, flexor digiti minimi brevis, abductor digiti minimi, and palmaris brevis. So these are the hypothenar muscles. Palmaris longus originates in the forearm. Do let me know that what is the nerve supply of adductor pollicis in the comments. So which muscle does not adduct the shoulder? So that is the supraspinatus, as we know that supraspinatus is one of the muscle which is responsible for the abduction of the shoulder. So you are supposed to know primary muscles which are responsible for different movements. The important movements which are frequently tested in the exam is the adduction and the abduction. So for the abduction, from 0 to 15 degrees we have supraspinatus, 15 to 90 degree we have deltoid, 90 to 180 we have serratus anterior and trapezius muscle. For adduction, we have pectoralis major, latissimus dorsi, and teres major. So a mnemonic to remember this is that in the bicipital groove, we have pectoralis major on the lateral side, latissimus dorsi in the floor of the bicipital groove, and on the medial side we have teres major. So remember that the structures which are present around the bicipital groove are responsible for the adduction, and for abduction we have these muscles. Now the medial rotation or the internal rotation is by the pectoralis major, deltoid, and latissimus dorsi, whereas the lateral rotation is by the infraspinatus and teres minor. So lateral rotation is by the muscles which are present on the posterior aspect of the scapula. So similarly, for the flexion, we have deltoid and pec major, and for extension, we have the posterior fibers of the deltoid and latissimus dorsi. So out of these, adduction and abduction are more important, but remember at least one or two examples of the flexion, extension, medial rotation and lateral rotation. So a well-toned weightlifter presented with weakness of the left arm. There is weakness of flexion and supination of the forearm. Which nerve is likely to be affected? So flexion and supination of forearm is performed by the biceps, and biceps is supplied by the musculocutaneous nerve. So musculocutaneous nerve can get entrapped between the biceps as well as brachialis, which is the root of the musculocutaneous nerve between these two muscles. So elbow flexion and supination will be affected. So as we know that musculocutaneous nerve arises from the lateral cord of the brachial plexus. It pierces the coracobrachialis over here and then it passes between the plane of the biceps. You could identify the two heads and the brachialis muscle. Now and it supplies these three muscles as well. After supplying these muscles, crossing the elbow joint, it becomes the lateral cutaneous nerve of the forearm and gives sensory innervation to the lateral area of the forearm. So this is all about the musculocutaneous nerve. So next up we have that which carpal bone is a sesamoid bone present in the tendon of the flexor carpi ulnaris. We have the pisiform. So here pisiform is one of the bones which is present on the medial aspect of the proximal row, and it is present in the tendon of the flexor carpi ulnaris as it passes from this area. So this small bone has a single articular facet. It projects from the triquetral bone at the ulnar aspect of the wrist, where most regard it as a sesamoid bone lying within the tendon of the MCQ. So woman develops winging of the scapula following mastectomy. It is because of damage to which of the structures? So damage to the long thoracic nerve during axillary dissection is the etiology for causing winging of the scapula. So as you see that mastectomy is performed in this area, and usually if there is a need to perform axillary dissection, then this area is opted. In this area, serratus anterior muscle fibers are present over here, and over those fibers run the long thoracic nerve, which is the nerve supply of serratus anterior. So if this gets damaged, there will be absence of function of serratus anterior, and as a result, there will be winging of the scapula. So next up we have a 23-year-old man falls and injures their hand. They may have a scaphoid fracture as there is tenderness in the anatomical snuff box. Which structure is making the medial boundary of the anatomical snuff box? This is the extensor pollicis longus. Anatomical snuff box is bounded medially or on the ulnar side by the extensor pollicis longus, that is this tendon, and then laterally or radially by the abductor pollicis longus and extensor pollicis brevis. So these two tendons are present on the lateral or the radial end, whereas this single tendon, which is the extensor pollicis longus, is present on the medial or the ulnar end. So if they give you the ulnar end or the ulnar boundary of the anatomical snuff box, it will again be extensor pollicis, but they give you the lateral word or they give you the radial border, then the answer could be between one of these, that is the abductor pollicis longus and extensor pollicis brevis. So which is not a branch from the posterior cord of the brachial plexus? So musculocutaneous nerve is arising from the lateral cord, as I've explained in the previous MCQs. So what is the mnemonic for the branches from the posterior cord? We have the star. Alright. So we have the subscapular, upper and lower subscapular nerves, thoracodorsal, axillary, and the radial nerve. So regarding brachial plexus, you should be very much clear that which cord is giving which branch, because these are frequently tested in the MCQs. So just a rapid overview. the brachial plexus arises from C5, C6, C7, C8 and T1. Now, there is only two branches from the roots, that is the dorsal scapular nerve, and it contributes to the phrenic nerve. So, phrenic nerve as well as the dorsal scapular nerve arises from the roots. From the trunk, we have two branches, the suprascapular nerve and the nerve subclavius. There is no branch from the divisions. Now, the lateral cord is giving LML, that is the lateral pectoral nerve, musculocutaneous, and the lateral part or lateral contribution of the median nerve. Medial cord is giving M4U. We have 4 M's and a single U. We have the medial pectoral, medial cutaneous nerve of the arm and forearm, medial contribution of the median nerve and ulnar nerve. So, ulnar nerve arises from the medial cord. Then we have the posterior cord. It gives star, as I have already explained. Axillary and radial nerve are the terminal branches, and the short branches are upper and lower subscapular as well as the thoracodorsal nerve. So, this is the overview, and I can guarantee that there is no other MCQ that can be tested apart from the things that I've already told. So, try to memorize them and try to implement your knowledge in the form of a diagram the way I have done, so that you can have a long-term memory, and try to remember the mnemonics that I give you in these videos. They will be very much helpful at the end of your final revision. So next we have that which structure lies between the lateral as well as the medial heads of the tricep muscle. So that would be the radial nerve. As I've explained in the previous section, that between the lateral and the medial head there is the radial groove. So from the radial groove passes the radial nerve as well as the profunda brachii artery. So between these two heads, this is the long head, this is the lateral head, and behind this or beneath this will be the medial head. So the radial nerve runs in the groove between these two heads. The ulnar nerve lies anterior to the medial head. Axillary nerve passes through the quadrangular space, and this lies superior to the lateral head of the triceps, and it is making the lateral border of quadrangular space. Now it is important to remember that which nerve is passing through which area.